Hi, everyone. I guess we can go ahead and get started. I want to welcome you to the third virtual town hall from the Program for the Elimination of Cancer Disparities. My name is Morgan Fouth, and I'm an epidemiologist for the City of St. Louis Department of Health, and I'll be your moderator today. Today's event is focused on colon cancer screening and care. We've titled this event, Can We Talk? Because colon cancer can often be difficult for people to openly talk about, and we want to both destigmatize this important issue and answer any and all questions you may have about it. For our viewers, we're not able to see or hear you, but we do want to encourage you to ask questions in the Q&A feature of Zoom. We'll be drawing on these questions throughout the event. Everyone should be able to see the Q&A, so if you do have any other thoughts or resources that you want to share, please share these in there or in the chat feature. But before I introduce our panelists, I did want to contextualize this conversation by sharing some of the latest data on colon cancer. So let me share my screen. All right, can everyone see that okay? All right, so here's a little bit of a breakdown of what we'll go over today. I'll show you incidence by year so you can see how colon cancer incidence has changed over the last 10 years. We'll go through incidence by county, so comparing the city and the county's data as well as the whole of Missouri. We'll go over incidence by age and also by race. So here you can see the incidence by year over the past 10 years. As you can see, for both the city and the county, colon cancer incidence has decreased over the last 10 years, most sharply in the city. And then there was also a slight increase in 2012. So here's incidence by county. As you can see, the city has slightly lower rates than the county does. Missouri, the whole of Missouri kind of being in between those rates. The incidence rates for the county for females was 28.3 per 100,000. Again, these rates are annualized per 100,000 and they're also adjusted to the US 2000 standard population. And then the rates for males in the county were 32.38 cases per 100,000. The city was slightly lower again at 26.66 for females and 29.17 for males. So here you can see incidence by age, and as you would expect, incidence increases by age. I wasn't able to pull any information for the age group under 35 because of confidentiality issues, so you can see that that starts at 35. The rates are about the same for the city and the county for the respective ages. Here you can see incidence by race. Colon cancer incidence races were higher for Blacks and African Americans than Caucasians in both the city and the county. They were about 8% higher in the city for Black/African Americans than whites, and they were about 20% higher in the county than whites. So a little bit more of a disparity we see in the county than in the city. So unfortunately, we don't have too much data on any of the other races. So I have included some race by counts here. So these are not rates, they're actually just counts, but you can see that whites take up the majority of colon cancer incidence, followed by Blacks or African Americans in both the city and the county. And this is only in 2017. So just thinking about that. All right. Okay. So now to understand a little bit more about these disparities and what we can be doing now to address them, I want to introduce all of our panelists. Today we have Dr. Tunji Toriola, an epidemiologist and associate professor in the Division of Public Health Sciences at Washington University. Dr. Damon Kleins, a community-based gastroenterologist and hepatologist in St. Louis, and also an assistant clinical professor in the Division of Internal Medicine at St. Louis University Health Sciences Center. Dr. Tracy Norfleet, a board-certified internal medicine specialist with BJC Medical Group of Missouri, and also an instructor of clinical medicine at Washington University. Maggie Augie, a registered dietitian for Siteman Cancer Center. Joanna Hayden, a stage 3 young adult early onset colorectal cancer survivor. So to start us off, why don't we have each of you tell us a little bit more about what you do with regard to colon cancer, along with a question to kick off the discussion. So Dr. Norfleet, we can start with you. And if you wouldn't mind just telling us a little bit more about what you do and then describe the different types of screening tests and how you decide which to recommend for each patient.
Good morning, everyone, and thank you for allowing me to be a part of this important discussion. My name is Dr. Tracy Norfleet, and I'm a board-certified internal medicine physician. I am an instructor of clinical medicine with Washington University, and I've been employed with BJC Medical Group for the past 13 years. An internal medicine physician is an expert physician who specializes in non-surgical care of adults and adolescents. I am a regional physician leader within BJC Medical Group, and I practice on the campus of Barnes-Jewish Hospital. My goal and passion is preventive medicine, and I strive to encourage my patients to remain active by preventing chronic diseases through a healthy lifestyle and regular exercise. So let's talk about the screening test for colon cancer. There are visual tests that can be done, and there are also non-invasive tests that can be done. The 3 types of non-invasive tests that we offer are stool tests. And stool tests are pretty convenient, and they can be done within your home. The first type of stool test is called a fecal immunochemical test. You may hear your physician speak of it as a FIT test. This test looks for blood in the stool that you will not be able to see with your naked eye. It is a convenient test, and it is done yearly. The second test that can be done is a guaiac stool test, which checks for blood in the stool as well. Once again, you will not be able to see this blood in your stool. However, this test is different from the FIT test in that you have to modify your diet before getting this test done. And last, the stool test, the multi-DNA stool test. And what this test does is it's a targeted test for DNA, and it also checks for blood within the stool as well. This test is recommended every 3 years should a patient choose to get this test. So these are our 3 non-invasive screening stool tests. The visual tests that can be performed are a little bit more invasive, but they allow you to visualize the entire colon. The first test is called the colonoscopy, and this is the test that we're mostly familiar with. A colonoscopy can be offered every 10 years or more frequently based on the findings. It's more invasive because you have to have some sedation prior to the test, and you also have to have a bowel prep prior to that test as well. The next visual test is called a CT colonography. This test is like a CT scan. However, you are required to do a bowel prep prior to this test. It's a little less invasive than a colonoscopy and does not require the sedation that a colonoscopy requires. And finally, there's the flexible sigmoidoscopy test. This is a test that allows the proceduralist to look at the colon. However, you cannot visualize the entire colon. You can only see the left side of the colon. So it's not a test that's commonly recommended by your primary care physician because of this. We're going to go a little bit more deeper into these screening tests. So once again, when we talk about our stool test, that FIT test, the fecal immunochemical test, is very easy to use. This test can be performed at home, and it requires a single sample of stool. Your diet does not have to be modified when you're doing this test, and it is done yearly. That second test that we spoke of, that guaiac stool test, this once again is a yearly test. However, you have to modify your diet and may have to modify certain medications prior to having this test. And then that final multi-targeted DNA test is commonly known as the Cologuard within the United States. This test can be done as well, and it requires an entire sample of your stool. This will be mailed to the lab, and then you will get a result telling you whether it is positive or negative. When we speak of these stool tests, the multi-targeted DNA test is the more expensive test that can be done on stool. When we speak more about the visual test in which the proceduralist can look at your colon, the first test, once again, is that colonoscopy test. And this is the test that you'll mostly hear your physician recommend. And we recommend this test for a variety of reasons. It is highly specific and it's highly sensitive. Since highly sensitive means that when it is positive, we're more likely to find something there. This test is usually recommended every 10 years, but you have to drink a bowel prep prior to having this test. And some patients shy away from that. So you may ask, why? Why do you choose that test? We like this test because this test not only detects, but can also treat the polyp if we find one. And so that way you can get one test done at one time and you're done. If you get a stool test or any of the other screening tests and they become positive, then you're going to have to get a colonoscopy test. And that colonoscopy test will no longer be considered a screening test. It will be considered a diagnostic test. The other tests I recommended or discussed was the CT colonography test. This test is a little less invasive because it does not require as much sedation. However, you still have to drink that bowel prep to get this test done. This test may allow polyps to be detected, but it can also miss some as well. And then finally, that flexible sigmoidoscopy test. This test does not necessarily require sedation and can be done in a doctor's office. But once again, you only see a portion of the colon, the left side of the colon. So it is not a complete test and is not the test that we routinely recommend. So you ask, how do we decide, or how do I decide which test to recommend for my patients? I take two things into consideration. The first thing that I take into consideration is what is the risk of the patient? Do I have an average risk patient, or do I have a patient who is at increased risk? Some factors that may increase your risk for colon cancer include whether you've had colon cancer before, whether you've had an advanced polyp on a previous test. There may be a family history of colon cancer within the family. And if so, you may need screening done earlier. If you've had an abdominal cancer and have had radiation as a child, you are at increased risk of colon cancer. And then there are also genetic mutations that will increase your risk if there's a family history. And last but not least, if you have an inflammatory bowel disease, such as Crohn's disease, then you are at increased risk of colon cancer. There are certain ethnicities that are also at increased risk of colon cancers, such as African Americans. So I discuss with my patient, what are their preferences? We do shared decision making when we're deciding which tests that they would like to perform or have performed on them. We look at costs, we look at availability, we look at convenience. All of these things matter and must be taken into consideration. But we must remember, as clinicians, having a test is better than having no test at all. So we want to make sure that some type of testing is done. The primary test that I recommend for my patients is that colonoscopy test, because we can find a polyp, we can find cancer, and then we can move on to treatment. It's that one-stop test that can be done. Remember, if we do any other of the screening tests and they are positive, we still have to go and get that colonoscopy test done. However, all patients may not want to get that colonoscopy test done because they're concerned about their risk. Maybe they can't tolerate the sedation. Maybe it's not convenient for them because you must have someone drive you to get that test done. So if that is not a good option for them, then I will default to the fecal immunochemical test. That is the test that is looking for hidden blood within the stool. Remember, it is a one-time test and it can be done conveniently at home and mailed to your doctor's office. When we get the results, we will tell you if that test is positive or negative. If it's negative, we will repeat this test yearly. If it's positive, then we must move forward with a colonoscopy. And then the third test that I recommend is that multi-targeted DNA test, the Cologuard test. This test can also be done at home. This test requires a complete stool sample, and it checks for hidden blood in the stool, in addition to possible DNA mutations that can be associated with polyps and with colorectal cancer. This test is done every 3 years. Because this test is not as specific, sometimes you can have a positive test, but then you get your, your colonoscopy done, and it may be negative. This is why I default to the colonoscopy test. Just get it done, and then we can move on. We all want to remember the importance of colon cancer screening, and we all should get testing done. I highly recommend that my patients get their testing done, and then from there we decide what the next steps will be. This is a life-saving procedure, and it's important to get the screening done.
Morgan, you're muted.
Thank you. Thank you, Dr. Norfleet. Next, we'll have Maggie Alge. How does your work align with colon cancer, and what should people know about the links between diet and colon cancer?
Good morning, everyone. Can everyone hear me? Yes, okay. I just want to say thank you for the opportunity to be a part of this panel. So I'm an oncology dietitian here at Siteman Cancer Center. I've been here for a little over a year now. My work here is pretty multifaceted in the sense that I mainly meet with patients and work with patients who are undergoing active treatment. But I also reach out to our patients who have already finished treatment and are under surveillance, and for those folks who are pre or post surgery. And I do a lot of preventative work when it comes to nutrition and cancer. I offer nutrition services to patients with all types of cancers, including colon cancer. In fact, a large amount of my referrals are for patients with some type of colorectal cancer. A lot of the work that I do with my patients is symptom management, which means that when I receive a referral, whether placed by the treatment team or a patient self-refers themselves, if they self-refer themselves, I offer nutrition interventions for whatever symptom or side effect that that patient is experiencing. So especially during active treatment. So when I meet with a patient, they may be experiencing, for example, weight loss, not necessarily due to a lack of eating, but more so due to frequent loose stools that they may be having. Excuse me. So I would address those issues with them and offer my nutrition recommendations. Another example is pre and post surgery. So they may not be getting active treatment, but they may be undergoing a surgery in the future or have had a surgery. For example, a colectomy, they've had their colon removed or a partial removal, and they may have an ostomy placed. So I would offer education regarding that and what to do from there on out. So a lot of my work, like I said, is for active patients in active treatment. moving on to the second question, which was links between diet and colon cancer. The links between diet, weight, exercise, and colon cancer are some of the strongest for any type of cancer. There's a lot of research that shows that there's increased risk for those folks who are overweight or obese, for those folks who are physically inactive. Even smoking and drinking alcohol can increase your risk for developing colorectal cancers. So the link, yes, like I said, the link between diet and colon cancer are some of the highest that are seen as far as research goes.
Thank you, Maggie. Next, we'll have Dr. Toriola. Could you tell us about your work with cancer research and maybe tell us a little bit more about what we should know about preventing and detecting colon cancer?
Thank you so much. It's so great to be on this panel, and thanks to the earlier speakers who have provided a wonderful overview and intro, very great intro on the topic. I'm a cancer epidemiologist, molecular cancer epidemiologist, and one of my areas of research is to understand causes of colorectal cancer and how we can improve quality of life, improve survival experience in patients who have colorectal cancer. And we know that colorectal cancer is the third most common cancer generally, especially in Black men and Black women. The incidence rate is 24% higher in non-Hispanic Black men compared to non-Hispanic white men, and about 19% higher in non-Hispanic Black women compared to non-Hispanic white women. So one of the things, also mortality rates are also higher in African-American men and African-American women compared to non-Hispanic white women. So one of the things that we have been trying to do is to understand why these disparities exist. As a result, we have an ongoing large multi-institutional study called the ColoCare study. The ColoCare study involves 7 cancer centers in the United States and 1 cancer center in Germany. And what we're trying to do is we're recruiting newly diagnosed colorectal cancer patients, and we're trying to understand, we're collecting biospecimens from them and also questionnaire related information so that we can understand how certain lifestyle factors and how certain molecular markers and genetic factors relate to their survival, to their recurrence, to quality of life, to toxicity to treatment, and also some other things that can affect quality of life in colorectal cancer patients. Right now, we've been able to recruit over 3,000 patients into the ColoCare study overall. And at WashU, we're focusing mainly on African Americans because they're really underrepresented in all these clinical studies trying to understand why colon cancer why we have colon cancer and molecular determinants of colorectal cancer response as well. So right now, one of our studies has shown that when inflammatory markers are higher, that could actually increase worsened survival experience and increase mortality. We've also been able to see that certain genetic markers as well can predict African-American patients who are going to have worse response to chemotherapy or worse survival experience. So this work is ongoing, and we hope that over the next few years, we'll begin to understand the drivers of recurrence, the drivers of toxicity to treatment, the drivers of worsened survival in African-American patients compared to non-Hispanic white patients. You also asked me to talk about some of the risk factors, if I remember that correctly. Some of the major risk factors driving the incidence of colorectal cancer include excess body weight, physical inactivity, high consumption of red and processed meat, moderate to heavy alcohol consumption, long-term smoking, and also very low intake of fruits and vegetables and whole grain fiber. And these are very important drivers of colorectal cancer incidence. Thank you.
Finally, we'll have Joanna Hayden. If you could tell us a little bit about your experience with colorectal cancer and what drives you in the outreach work you do.
Yes, of course. Absolutely. Good morning. It's an honor to be here and to share my story. So in May of 2019, I was 31. I was definitely in the best shape of my life. I was a marathon runner. I was a local cycling instructor here in St. Louis and a full-fledged vegan. Not to mention I had no known family history, and I did not have a single risk factor that would increase my risk of having colorectal cancer. Despite all of this, I was diagnosed with stage 3 rectal cancer. Before my diagnosis, I experienced multiple symptoms. I had abdominal bloating and just abnormal bloating in general. I had pretty intense digestive issues. I consistently had blood in my stool. I had abdominal pain, unexplained fatigue, and just unexplained weight loss. And I had these symptoms for about 18 months. Unfortunately, I vocalized these symptoms to many healthcare professionals who advised that I likely had a dairy intolerance, gluten intolerance, or very likely had IBS. When I made a lot of behavioral and just life changes, nothing really changed. So I really couldn't do much more because I was just in constant pain and discomfort. So I insisted on a colonoscopy, which I found out I had stage 3 rectal cancer. So now in my survivorship, I'm a board of director for Fight CRC, as well as a captain and a top fundraiser for Pedal a Cause. And in those roles, I so strongly believe that sharing my story matters in an effort to spread awareness. I advocate because my diagnosis was most definitely overlooked. And it's likely because of my age, my pristine health, and my lack of any risk factors, notwithstanding the fact that I presented multiple times with what I call textbook rectal cancer symptoms. My hope is that despite a young adult who appears to be healthy, medical professionals will continue to recognize that cancer can present in anyone, and that screening, like Dr. Norfleet stated a couple minutes ago, it's important and it saves lives. And I always go back to this phrase that cancer does not discriminate. So at the end of the day, screening is just so important. Thank you.
Thank you, Joanna, for sharing your story. So now we'll move into the Q&A portion. So again, anyone feel free to post your questions or resources in the Q&A or the chat feature. We do have one question in the Q&A. I believe this will be directed towards Dr. Norfleet. And the question is, I've had a polyp removed on a prior colonoscopy. I don't think I have had any yearly tests done since then. They said I need to return in 5 years for repeat colonoscopy. Based on what you stated, I should be having a yearly guaiac or FIT test, correct?
Let me clarify that. So the yearly test, the yearly stool test is done instead of a colonoscopy test. So the fact that you had your colonoscopy test done, you follow the recommendations based on that test. So you do not need a yearly test in between the colonoscopy test.
We do have some prepared questions, so I can move into some of those. To Maggie Algie, are there certain foods that raise your risk of colon cancer? And does eating these foods at a young age impact your risk later in life or impact your risk of getting colon cancer at a young age?
Yeah, so these were kind of touched on by Dr. Toriola, but certain foods that can raise your risk for colon cancer include, so a diet high in red meats, so that's your lamb, beef, pork, diet high in processed meats, so things like hot dogs or sausage or deli meats even. All of those can raise your risk for colon cancer. In addition to the types of meats, also how you cook your meats can increase your risk for colon cancer. So cooking your meats at a very high temperature, such as frying, broiling, or even grilling, can create chemicals that can raise your cancer risk. Those are the main things that can raise, as far as specific types of foods that can raise your risk of colon cancer. Now, eating these foods at all, research shows that it raises your risk. So I do believe that eating these at any age can increase your risk for getting colon cancer later in life. So it's important to keep these at a minimum, keep your portions at a minimum, and how often you eat these types of foods. Their recommendations for red meats for the average individual is two servings a week. So that's two servings of, a serving is a 4-ounce piece of red meat. So that a 4-ounce steak or a 4-ounce piece of lamb, etc. So just twice a week is the recommendation. And then other foods that can reduce your risk of colon cancer is a diet high in fruits and vegetables, a diet high in fiber, making sure that if we're eating meat, we are choosing things that are lower in saturated fat, such as different types of seafood products, things like chicken, other poultries, stuff like that.
This next question kind of made me think of your story, Joanna, but it's on the subject of Chadwick Boseman and his death. So Dr. Toriola, could you explain how this could happen, Chadwick Boseman's death at such a young age?
Yeah, thank you. And thanks, Joanna, for sharing your story. We've been seeing an increase in the incidence of colorectal cancer in young adults now, and it's quite alarming. The increase over the last few years is quite alarming. We have somebody in our study, colloquial study, who was diagnosed at the age of 23 years old, which is really alarming. And that's why some of the recommendations from the institutions such as American Cancer Societies, they encourage screening to begin at an earlier age 45, but I don't know whether we can actually get screening to begin at a much earlier age. We have to think of the positive predictive value and the negative predictive value among patients, potential patients who are much younger. But yes, we're beginning to see an increase in early onset colorectal cancer. This is an emerging field, and there's a lot of studies that are being done to understand why. We're beginning to have some insight, and one of the insights could be obesity. The trend in obesity in the United States has been increasing over the last few decades, and some people think that this may be one of the drivers of early onset colorectal cancer. As for the other potential drivers, there's still very limited knowledge because, like I said, it's only in the last few years that we began to understand this phenomenon, and we're beginning to actually look into studies that can determine whether there are molecular differences between people who develop early onset colorectal cancer and those who develop adult onset colorectal cancer. So I'm hoping that in the next few years, we'll begin to have more insight and more knowledge on what really drives younger people to have colorectal cancer at this stage. Unlike for adult onset colorectal cancer, where the incidence has been decreasing by about 2.5% every year for the last 10, 15 years, the incidence of early onset colorectal cancer has actually been increasing. So that's a place we have to really put a lot of focus on, a lot of research insight into understanding why this is.
Along those lines, could your risk at 45 be about the same as your risk at 55, Dr. Toriola?
And that's a very great question as well. A study that was recently performed in Kaiser Permanente showed that it's a very large study, and what they did was that they started screening people at a much earlier age, and they discovered that they found the same number of adenomas and the same number of cancers among those that were screened at age 45 compared to those that were screened after age 55 and 60. So it's possible that if we don't screen early, we're going to be missing quite a few number of potentially treatable cancers. In terms of absolute numbers, these numbers may not be large, but for somebody who has cancer, it's 100% for them. So those are things that we have to consider. So yes, I think from what we know, this study was just published about a few months ago, and this is one of the first studies to look into this. So yes, the risk among people who are around 40 to 45 may just be approximately similar to the risk among those who are a little bit over 50 and from 50 to 60 as well.
Okay, thank you. So we have a question in the chat box. If my colonoscopy, and this is to all panelists, if my colonoscopies return okay with what was diagnosed as a non-benign appearing polyp, is it still advisable to continue to get them every 5 years? What if this non-benign appearing polyp changes? What if it changes?
I can help with that. So when you had your colonoscopy done, that polyp was removed, which means that that risk of that polyp turning into cancer is no longer there. So the purpose of you getting a colonoscopy done in 5 years instead of 10 years is so that they can look and see how fast are these polyps growing. So in other words, that polyp is gone. You shouldn't have to worry about that one. But now your specialist is being a little extra careful and getting a test done sooner than 10 years to see how fast are these growing, or if you've developed another one. And after you get this test, they will determine if you can get a test in another 10 years if nothing is found, or based on if a polyp is found, the type of polyp, the size, and the amount, you may have a frequency that is a little sooner. But the reassuring point is that that polyp, that benign appearing polyp, is no longer there.
Okay. So on the flip side, if it's benign appearing, what should she do? So non-benign appearing versus benign appearing.
Yes, so benign appearing means that it is not precancerous. So usually when you have polyps, they will send that polyp to the lab, and the pathologist will look at the polyp and tell you what type it is. A benign appearing polyp is what we call a hyperplastic polyp. That in this type of polyp, you don't have to get any sooner screening. Benign means that it's non-cancerous. However, you can have adenomatous polyps. And adenomatous polyps are considered precancerous. But that's the best part about the colonoscopy, is that that polyp, that precancerous polyp that may turn into a cancer in years, has been removed. So if you have a benign polyp, the routine screening is usually 10 years unless there's some family history or other risk factors. And then if it's a precancerous polyp, then usually the recommendation will be for sooner frequency. As an internal medicine physician, we follow the guidelines of what the gastroenterologist recommends. So you may find that if you talk to friends or family members, you may not have the same recommendations. But if you have any questions or concerns, absolutely address them with your primary care physician. The other thing to consider is that the colonoscopy that you're getting is a screening colonoscopy, which means you don't have any symptoms. But when we listened to Joanna, she had symptoms. So should you develop any concerning symptoms or any symptoms that you just want to discuss with your primary care physician, it may be indicated to get a colonoscopy sooner. If you have symptoms such as abdominal pain, blood in your stool, that colonoscopy is no longer a screening colonoscopy. Because you have symptoms, it is now a diagnostic colonoscopy.
Thanks, Dr. Norfleet. The next question in the Q&A, what are the relative costs of screening for people who have to pay out of pocket?
Now that is a hard one. I won't get any answers from anyone else besides me, but I will try to help you. I can tell you that the FIT stool test is one of the cheaper tests to get done. I don't have exact quotes on that, but it can be anywhere from $100 or less. The other stool test, which is the multi-targeted DNA test, it's more expensive than the FIT test, and can be anywhere from $300 up to $600, and do not quote me on that. And then finally, you also have the GUAIX stool test, which is going to be definitely cheaper than the DNA test, and I'm not sure what the range is where in comparison to the FIT test. All of the stool tests are going to be cheaper than the visualization test, if you can imagine, because the visualization test requires a physician, may require anesthesia, and may also require imaging. So if you're looking for a cheap alternative, but still something that is effective, I would recommend getting that FIT test, that fecal-immunochemical test done. A lot of times you can check with different labs to see what the cost may be. And you may also be able to go to a community health center and get testing done where they can look at your income and base testing on the income.
Thanks. I would like to add to what Dr. Knopfler has already said. Yes, those price ranges are what we've seen in different health centers. A study that was done by the New England Journal of Medicine, published just a few years ago, showed that the average cost of the FIT test is about $20, and the average cost of the FIT DNA, the Cologuard test, is about $502. So yes, those ballpark range, depending on the system, depending on where you are, it will fit in rightly with those quoted figures.
Along those lines, do we know if insurance will cover the cost of care for someone even if they're really young?
Insurance, as far as screening tests go, you always should check with your insurance for coverage. Most insurances will cover some type of screening test for colon cancer. The age at which they will cover that test does vary by insurance. And what was can you repeat the question again? I want to make sure.
Yeah, it was, do we know if insurance will cover the cost of care even if someone is young?
Okay, so usually if you're young and you're not getting that screening test, because remember, screening tests are covered. So if you're young, like Joanna was, and she had symptoms, then you're not getting a screening test, you're getting a diagnostic test. Usually those tests will have some costs that will be incurred by the patient, but your insurance company can tell you what those costs would be. And if you're getting a colonoscopy, that can be costs from the cost of the sedation, the cost of the physician, and also the cost of the follow-up testing as far as if a polyp is removed and the reading of the pathology. So it does vary.
Okay, thank you. Kind of going back to Chadwick Boseman's story, and this is another question from the chat to any of the panelists, do we know if Chadwick Boseman had any symptoms?
From what I know, I'm not sure if Chadwick had any symptoms. He may have had some symptoms, but may have not known that they were symptoms of colon cancer, or unfortunately, because Chad was so young, and like in Joanna's case, it took a while for the diagnosis to be made. There may have been a genetic component. There may be some family history there that we may not be aware of, but it's hard to know. I'm not aware of the history, his past history.
Thank you. Again, along those lines, if you are under 45 and you do feel healthy, should you still get screened, regardless of if you have symptoms or not?
The recommendation for getting a colonoscopy at the age of 45 are for high-risk groups. And in my readings, that would be African Americans. So I would highly encourage you to check with your insurance company to see if screening is covered. Because if you think about it, 5 years is a long time. And I keep referencing Joanna because she was so brave to tell us her story. But can you imagine if we waited 5 years for Joanna, and what the prognosis could have been much worse had we waited any longer? So I would recommend that if your insurance covers a colonoscopy, excuse me, at the age of 45, I would go ahead and get it done. Just think about it. No one has seen the inside of your colon for 45 years. So let's get it checked out. If there's polyps, get them removed, and then you can decide from that point when you would like to get screening done after that.
Okay, thank you. To Dr. Toriola, you kind of talked about this a little bit earlier, but does risk differ among racial groups, and what about genders? Are men more likely to get colon cancer?
Yes, very great questions. Yes, the risk differs among racial groups. We know that African American men are at the highest risk. They have a 24% higher incidence or risk compared to non-Hispanic white men. Also, African American women, they have a 19% higher risk than non-Hispanic white women. So overall, the risk is highest among African American men and lowest among non-Hispanic white women. For instance, certain figures that we have, the incidence rate for African American men is about 52 or 53 per 100,000 people, whereas for non-Hispanic white women, the risk is about 11.9 per 100,000, or sorry, 16.6 per 100,000 people. So you can see that there's a very big difference in the risk and the incidence rates by gender and also by race and ethnicity. And the same applies to mortality or death as well.
Okay, thank you. So moving into a pretty relevant topic of today, talking about COVID-19 and colon cancer. If a person already has cancer, how does contracting COVID-19 affect them? And this is to any of the panelists.
If someone already has cancer, that means that their immune system may not be as strong. So you certainly would be at increased risk of contracting the COVID-19 virus. Currently, our rates are climbing within the city and the county. So what we would recommend is to follow those precautions, which are isolating yourself, not getting in big gatherings, hand washing, and wearing your facial mask and making sure that you're social distancing. But you certainly are at an increased risk if you currently have active cancer at this time.
And one thing that has also been noticed is that because of COVID, people seem to be presenting later for care with their symptoms. So there is a trend that people are going to be diagnosed at later stages, which doesn't augur well for prognosis and clinical outcomes.
Yes, what we find in primary care currently is a lot of patients are delaying seeing their physician for fear of coming into our offices. But I do want to remind you or let you know that most doctors are doing telemedicine, which allows you to do a video visit from home. That means that if you are having symptoms or any symptoms that you would like to discuss, you can stay in the safe environment of your home and still have a doctor's visit via a video to see what is going on. If your doctor feels that you need to come in, safety precautions are being done within our medical facilities. So we are screening every person that comes within our medical facility for symptoms. If they do have symptoms, we are not allowing them in, but rather directing them to a telemedicine visit. So we're trying to keep our facilities as safe as we can. And to be quite honest, I feel more safe going to work than going to the grocery store.
Kind of jumping off of that, our next question goes to Joanna. People living with cancer during COVID-19 pandemic have had to take extra precautions for themselves to keep them safe. What advice do you have for someone who is maybe recently diagnosed and wondering how to keep themselves safe? Or maybe someone who is just putting off screening for fear that they'll find out they have colon cancer during this global pandemic?
Great question. So I think to individuals who have been recently diagnosed, I think it's important to recognize that your body and your immune system, as Dr. Northfleet had said, it's just different. It's going to be different when you're going through chemotherapy and radiation for your treatment. I'm only 11 months after treatment right now, and I have recognized during the pandemic that my body is still very much healing from the treatment I went through for about a year. So personally, I'm very cautious, and I wholly respect the fact that even 11 months post chemo, that as an individual who has had cancer, COVID could pose more of a threat if I was to contract it. So I think just recognizing that life's a little different right now, and to be extremely thoughtful about the situations that you put yourself in, and that small group of people that you engage with. And I would say for individuals delaying a colonoscopy for probably a whole host of reasons, my biggest piece of advice is do not delay. After I was diagnosed, for weeks, I would say weeks, I replayed the same question in my head of, what if I had insisted on a colonoscopy sooner? Would my cancer be stage 1 or stage 2? I share that because having a colonoscopy, it very much provided me with peace of mind, maybe not initially in my circumstance, but I was able then to have the information I needed to tackle whatever was ahead for me. And really it provided me with the answers that, okay, I'm not going to feel this much discomfort and pain forever. I found the source of the problem. And so I think just do not delay. That'd be my biggest piece of advice for you, as elective procedures are being allowed right now. I would say use all your resources at the hospital that you go to. As Dr. Norfleet said, telemedicine, contact your doctor. There are a lot of ways and a lot of smart people who have found creative ways to continue to provide healthcare.
Thank you. This question is to Dr. Norfleet. You did talk a little bit about telemedicine earlier. So what are practitioners doing right now to make telehealth more accessible? And then another question, how is it decided who will get priority when there is a COVID-19 vaccine?
So to make telemedicine more accessible, we don't rely on just one platform. We try to make it as easy as we can for our patients. So we use FaceTime, we use Zoom, we use Doximity, whatever type of video platform you have, we are willing to work with you to use that. And if that's not available, we even offer telephone calls. So our goal is really to help you figure out what's going on and to keep you safe within your home, should you choose to do so. As far as the COVID vaccine that will be available hopefully soon, guidelines will be followed as recommended by the CDC on who gets priority for these vaccines. Some reports have said that the vaccine will be initially offered to healthcare workers who work in long-term facilities. It will also be offered to healthcare workers who have chronic conditions. It will also be offered to critical infrastructure workers, and then it will be determined after then who gets it next. Eventually, everyone should get the vaccine, but of course, initially there will be a limited supply.
Thank you. Another question for Joanna. What resources helped you during treatment, and what kind of support did you receive after diagnosis? And then what kind of support has been helpful since your cancer went into remission? Oh, Joanna, you're muted.
Okay, got it. I would say hands down, one of the biggest resources for myself, let me start over. So in terms of just like my treatment, I utilized every avenue I could. I became very close with my nurses, my nurse practitioner, and my oncologist, Dr. Tan. I 100% had world-class treatment at Siteman. In terms of just like an emotional support, which I think is just as important during your treatment, hands down, my biggest resource came from other women who had gone through a similar diagnosis, and just women in general who were dealing with cancer. My treatment was definitely different because I had a lot of in-person interactions with people during treatment, after treatment. So in a time when life is more virtual, I would encourage people to join Facebook forums with national organizations such as Fight CRC or the Colorectal Cancer Alliance. They will provide you an abundance of resources to join podcasts and other town hall meetings and to meet people very much in a similar circumstance as you. I would encourage people to engage with our local cancer support center, to join the Young Living group with Pedal the Cause, or to actively engage just on social media in general. This is something for me that definitely helped, was to find commonality with other cancer survivors, patients, caregivers. So in fact, I met a woman who lives in Vancouver. We were 5 days apart in our diagnosis. We are both stage 3 colorectal cancer. We both had stage 3 rectal cancer, and we were both in our early 30s. We have become extremely great friends. We connected about the ups, the downs of treatment, and now together, virtually on the phone, we're navigating survivorship together. And I know for me, that piece has been really huge. If I can jump into survivorship, I think transitioning back to life after treatment is extremely challenging. The level of support and attention I received during treatment, as I said, hands down world-class. I would say though, if there's an area of opportunity in the cancer community, I think it is to assist patients in navigating that transition to life after treatment. As a young adult in particular, many women, including myself, we face early onset menopause in our early 30s, and just the emotional loss of infertility. It's devastating. And so in my opinion, there needs to be more attention on bridging life from treatment to survivorship. And that's very much something that I would love to get involved with, because as someone who is very much still, dealing with a lot of those effects of treatment, I just find it to be extremely important to have those resources.
Thank you, Joanna. What services are available to help uninsured or underinsured people get access to colon cancer screening, follow-up appointments, or care? Transportation services, social services, mental health services, etc. This is to any panelist.
Well, I can say that you can certainly contact BJC. We do have programs for patients who have difficulty with paying for services, and you can apply for those programs where you are still allowed to see a BJC physician and still allowed to get the preventive care that you need. Other resources perhaps would be to go to community health centers in which you can get care based on your income, and you can get your services done there as well.
And then our last question to Maggie: what are some healthy eating choices people can make to help lower their risk of developing colon cancer? And how can someone make those choices while living on a tight budget or in a food desert?
So to reiterate, some of the healthy eating choices include increasing your intake of fruits and vegetables. And when you're talking about a tight budget, fresh produce is sometimes hard to come by, especially in a food desert. And you don't, in order to eat fruits and vegetables, it does not have to be fresh produce whatsoever. If frozen foods are available to you, that is the next best thing. In fact, frozen foods, especially the ones that don't have extra sauces or gravies or whatnot added to them, they're just as healthy, just as nutritious as fresh produce. So that's a second option if fresh produce is not available to you. So frozen, and then even after that, canned fruits and vegetables are just as good as well. In fact, year-round canned vegetables and frozen vegetables are almost always available. When certain produce is not in season, then definitely choose frozen or canned. So like we mentioned earlier, trying to limit your processed meats as well as your red meats can definitely help decrease your risk of colon cancer. and then choosing a diet higher in fruits and vegetables. And also there's some current and recent research out there about increasing your fiber as well. So that's including, you know, fruits and vegetables, your whole grains, so things like brown rice, whole grain pasta, whole grain bread, etc. All of those can help decrease your risk for getting colorectal cancers. And one of the reasons is not only does fiber help with weight maintenance and preventing weight gain, is that fiber can also slow the process it can increase the process of your GI tract. So these foods are in your GI tract a little less, and they can go through your GI tract pretty quickly. So fiber can help in a lot of different areas. So not only fruits and vegetables, but also increasing your whole grain consumption can help as well. We mentioned a little bit about alcohol earlier. If you do drink, for men, the recommendation is 2 drinks a day at a maximum, and then for women, it's 1 drink a day as well. And then there's a lot of research out there as far as the right diet to follow. And if we put a label on it, the Mediterranean diet is one of the highest recommended diets to reduce a lot of cancers, but specifically colorectal cancer. The Mediterranean diet is full of fruits and vegetables. It really focuses on eating seafood, as well as your healthier fats such as avocado and olive oil as well. In fact, this type of diet, research has shown there's a 45% decrease in risk for your colorectal cancer for the patients and individuals who follow this type of diet as well.
Thank you, Maggie.
Mm-hmm.
If anyone has any last few questions, feel free to submit those to the Q&A in the chat. We do have a little bit under 10 minutes left if you do have those questions. And then while we're waiting for those, Joanna, I just wanted to make sure you saw in the chat some comments from Linda Joyner. She said, Joanna, I admire your courage and resilience. You are such a fighter and an example for all of us, and thank you for sharing your story. So.
Thank you, I appreciate it. Thank you.
Okay, we do have one other question. Can Joanna tell us a little bit more about her survivorship story? Also, what does she recommend to individuals who are under 45 but are experiencing symptoms?
Sure, I'll start with recommending to individuals who are under 45. So what I would say is be really vocal with how you're feeling. If symptoms persist for weeks, months, trust yourself. That is something I wish I would have done a little bit better. I was told I was okay and it just continued. Be vocal. It's your life, it's your body, it's your journey. And you always have the option, if you need to go to a different provider who maybe potentially will listen to your symptoms more. That is a similar story. I actually have 8 women. We're all colorectal cancer survivors, in particular stage 3 rectal survivors from around the country, the world actually. And we all have a very similar story. We presented with almost every symptom for anywhere from 12 to 18 months. And we said something is wrong, but we really didn't push. And what I would say is, from someone who has battled through chemo and radiation and now a lot of just hard things in survivorship, speak up for yourself. It's your body, you'll know best. In terms of survivorship, I would say if you are a survivor or if you're about to finish treatment and enter survivorship, congratulations. You know, it's a really amazing club to be in, right? But it does come with a whole host of problems. So, and side effects and just, you know, issues to deal with. And so in the beginning, it can be daunting, but again, I would say reach out to your healthcare professionals. If you feel as though you're not getting the right navigation there, reach out to forums. If you're having a problem, it's very likely other women and or men are having the same problem. So right now I'm about 11 months, actually December 7th will be 1 year since I finished chemo. And so I'm a non-operative patient. I actually never had surgery. So I'm in a kind of a small group of people who has complete response from radiation and chemo. And so it's kind of a riskier path to take, but we did take that path, and I will be under the close watch of Dr. Tan and Dr. Much for another 4 years. And so I would say kind of my last piece is just make sure while you're advocating for yourself that you also feel trust and confidence in your team. I think for my husband and I and our whole family is that really, regardless of what was going to happen during that treatment, we 110% knew that our healthcare professionals would be able to navigate what happened. I think that's a huge piece, is that you got to believe in the people who are saving your life. But other than that, join forums. If anyone needs to reach out, I'm part of a lot of groups in St. Louis, and I would love to connect you with men and women who have been in your shoes. So thank you.
Thank you, Joanna. One more question for you. What survivorship resources would have been most helpful for you?
Yeah, so I'm pretty open about this. I went through early onset menopause. It was something that was talked about, but when I finished chemo, I really didn't understand that was going to happen until a couple months after. And so, to be honest, I felt unprepared for it. I don't really know how well you can prepare for menopause, but it was hard. I didn't really know who to go to. My oncology team, that they sent me to a couple people. So I think understanding that clear navigation of somebody helping us navigate who we best go to, because once I was able to find the right person, I then had a plan, and we rolled with it. And I think just also recognizing that, mental health, our emotional capacity for all of this is equally as important as the chemo and radiation that we're receiving. And so I would say just more of a push on those types of resources, I think, are really important, because, there's not only an acceptance piece of I have cancer, there's an acceptance piece of a lot of other things. Life is different. It's not ever going to go back to normal, whatever that consists of, but it is different. And I think that navigation piece with really mental health and just, overall assistance after survivorship is needed.
Thank you, Joanna.
You're welcome.
I don't see any other questions in the Q&A or the chat, so we can adjourn a little bit early. I do want to say thank you again, Joanna, for sharing your story. Thank you to the other panelists for sharing your expertise, and for Kelly and Marilyn and Keisha for organizing and having us. So have a great day, everyone.
Thank you.
Thank you, everyone.
Thank you.